that's the only approach that we can do. But 5 of the 6 classes of drugs that we are talking about would involve serotonin. So serotonin's innervation involves in all over the brain. Okay, so it is involved in emotion, cognitive functions, hormone secretion, sleep, appetite, and sexual behavior. So it's involved in many, many places. But what this slide did not emphasize is that there are some serotonin in the spinal cord that's going down. They are also involved in modulation of pain perception, as well as the response to pain. So some of the drugs that we talk about today are also used to manage pain. And now I'll point them out later. So the emphasis for serotonin is based on some of this evidence. In depression patients, there are decreased 5-HT levels in the cerebral spinal fluid. So that's one suggestion that, maybe we need to increase 5-HT. And also, in them, the levels of plasma tryptophan is lowered. And tryptophan is the amino acid that is the precursor of 5-HT, is serotonin. So they have lower tryptophan. And then if you give serotonin to the depression patients, their response in neuroendocrine response are typically lower than a normal population. So this also suggests that the 5-HT system is abnormal in them. And then also in them, there's a presynaptic increase in presynaptic alpha-2 receptor. And presynaptic alpha-2 receptor typically is involved in suppression of neurotransmitter release. So this all suggests that there will be increase in the sensitivity. So this all suggests that there are some abnormality in the 5-HT system in depression patients. But just like all of the brain disease that we have talked about, there are exceptions, and there are evidence that might actually contradict in the predominant, the prevalent hypothesis. For example, in some depression patients, the 5-HT is actually elevated. So in most of them, the 5-HT level in CSF is lower, but in some actually it's elevated. So that hypothesis is not watertight. And then approximately 30% of the depression patients do not respond very well to SSRI. So it's not a treat-all, end-all, be-all, end-all treatment. And then a drug that inhibits tryptophan hydroxylase, which would decrease the amount of 5-HT in the brain, actually can relieve depression symptoms in some patients. So this inhibitor would block this step. This step is involved in turning tryptophan into 5-hydroxytryptophan, and then which would turn into serotonin. If you block it, in theory, you could decrease the level of 5-HT. But in some of these drugs, this actually never turned into a drug. It was tested as a clinical trial, and it worked in some patients. But the other side effects, as well as the efficacy, was not that great, so it was never marketed. So the idea is that I just want to let you know that we believe 5-HT is very, very important, but that probably is not the complete story, okay? So this is simply say that 5-HT receptor neurons, dopamine neurons, and norepinephrine neurons, they are actually talk to each other, and then together they would affect the brain function. So this is simply let you know that all these monoamines are very interacting with each other. And so, this is my style, right? Anything that is in color means that you need to know. You need to know very well. So we are going to talk about these 6 different classes of drugs. As I mentioned, that 5 of these 6, they will always involve serotonin. Selective serotonin reuptake inhibitors, serotonin norepinephrine reuptake inhibitors, mixed serotonin compounds. This is the only one that does not involve serotonin, or most likely don't. Norepinephrine dopamine reuptake inhibitors, monoamine oxidase inhibitor would elevate serotonin level, serotonin alpha adrenergic receptor antagonist. So all these, most of them would involve serotonin because this is the best screw that we know how to turn. Okay? All right. So this figure summarizes all of the drugs that we talk about and where and how they work. And I would dig deeper into each one of them when the respective class come along. But I just want to give you an overview of what this graph means. So this represents a presynaptic noradrenergic nerve ending. Norepinephrine is synthesized in this neuron, packaged into a secretory vesicle, and then when the action potential come along, it will release norepinephrine. Norepinephrine and then would act on the postsynaptic receptor, and then some of them would be reuptaken by the norepinephrine transporter, NET, into the neuron, and then some of them will be degraded by MAO, the monoamine oxidase, and then those that are not degraded would be recycled and used again and for the next round of secretion. And same thing, this is a 5-HT serotonergic presynaptic neuron. 5-HT is synthesized, packaged, released, and then work on the receptor, and then some of them would be reuptaken by the serotonin transporter back, and then some of them would be hydrolyzed by the oxidized and then hydrolyzed by the monoamine oxidase. Those that are still intact would be reuptaken into the vesicles and then recycled. So this is how it works. And all of the drugs that we are talking about, the whole goal is to increase the level of norepinephrine or 5-HT at the synapse level. Okay? So that's, remember this main principle is we want to increase the amount of neurotransmitters at the synapse. Okay? Now, there's one class that doesn't involve serotonin. So the idea for that class is norepinephrine and dopamine level is increased. So that's it. All right. One concept I want you to know for sure, that in all of the antidepressants that we give to patients, once you start treating the patients, it typically takes many weeks, in these numbers represent weeks, generally 3 to 4 weeks and maybe up to 6 weeks before you see an improvement of the symptoms. Okay? But if you measure synaptic effects in the brain, look at brain functions, or side effects, those effects happen within hours or days. So the drugs actually gets to the brain very quickly, but it takes a long time before the antidepressant effect to show up. Okay? So this is called a therapeutic lag. Why? We are not absolutely certain why, but these are some possible reasons. That it is not simply you elevate the concentration of the neurotransmitters in the synapse that will immediately do the magic. It probably takes some other adaptive changes in the brain in order to really react to them to be antidepressant. So some of these adaptive changes have been proposed. There may be increase in density or sensitivity of some of the postsynaptic receptors. It takes a while for them to be synthesized, to be upregulated. Or the receptor G protein coupling strength efficiency may be improved over time. And is after that, then you see the improvement. And also maybe that you need to induce the expression of neurotrophic factors or neurogenesis. There will be actually new growth of nerve endings, neurites in the hippocampus. All of these have been observed, mainly in animals. Whether they truly explain the therapeutic lag is not clear. But all you need to know is that there is a therapeutic lag in all of the antidepressants that you give to patients. So do not stop treatment after 2 weeks. You don't see an effect, right? So you need to observe it longer. All right. I just 2 years ago, last year actually, I looked at the most frequently prescribed drugs in the U.S. And you can see that there are many of them on the top 300, but even in the top 100, there's 11 drugs of that. If you add them together, that's like about roughly 10% of all of the prescribed drugs in the U.S. And I read that about 10% of the adult population during their lifetime, they have used one of these drugs. Okay, so depression is a major problem. And also I want you to notice that along this list, all of the drug classes are involved except MAO inhibitors. Okay, all of the 5 or the 6 drug classes are on this list. So they are all very useful. And then you can see that a lot of them are SSRIs. Okay, so SSRIs, SSRIs are very important drug class as an antidepressant. Okay. As Dr. Cohen already mentioned, that suicidality is a major concern for all antidepressants. So they would have an increased risk compared to placebo in all of the clinical trials. There are increased risk of suicidal thinking and behavior in typically younger children, adolescents, and younger adults. In older folks, I think they get used to the unfairness of life, so they don't try to kill themselves as much. But then the younger ones, they are more likely to have suicidal thoughts. So this is a major thing to observe, to monitor. Okay, so I'm going to dig into all these 6 classes of drugs, but I want to start with the least specific and then move to the more specific, to selective serotonin reuptake inhibitors. So let's start with monoamine oxidase inhibitors, MAOIs. MAOIs work at here. So it inhibits the enzyme MAO, which is involved in causing oxidation of reuptaken norepinephrine or reuptaken serotonin. By blocking that would allow more of the reuptaken norepinephrine or serotonin to be available to be repackaged into the secretory vesicle to be released again. So that's how they work. This is one of the first antidepressant drug class. And as Dr. Emmett mentioned, that we need to inhibit MAO-A because MAO-B mainly inhibit the oxidation of dopamine, right? MAO-A is dopamine, norepinephrine, and serotonin. So we need to inhibit MAO-A. So this is how the function of MAO is to oxidizing this amine into an aldehyde, and then this is further oxidized into acid. So as Dr. Emmett already mentioned, that most of the drugs on the market for MAO inhibitors, they are really not selective to inhibit MAO-A. They are inhibiting all of both MAO-A and MAO-B. So all the drugs currently are either inhibiting both MAO-A or MAO-B, or sertraline, which is used for Parkinson's disease. At the lower concentration, it would inhibit MAO-B, but at high enough concentration, it can inhibit MAO-A. So when we are using this drug to help depression, then in fact it becomes non-selective, right? Because you need to use high concentration. This class of drugs are not very popular because toxicity and major food and drug interactions. The major food and drug interactions, many of the fermented drugs that they can turn